So good afternoon. I'd like to thank people for attending. If I have some traits, one of which is to try and start on time because I think it's respectful of you and moving ahead. And there is a second session that starts at, I believe, 3 o'clock. So welcome. First of all, introductions. My name is Fred Swaine and I'm the CEO for EORLA. Harry?
Harry Swaine, Vice President of Operations, 26 days in the job.
So what I like to suggest, we have a brief presentation that I like to run through. If along the way that you do have questions, we can answer them then or at the end. So it's your choice. The only thing I just like to point out that we would like to be done in an hour because we're having a repeat session for people that can't make this one. So without further ado, just what we'll be running through in the presentation. What is EORLA? Why is it? What's the rationale? What is EORLA going to do? And what are some of the things that EORLA is not going to do? So first of all, what is EORLA? EORLA is a voluntary or integration of laboratories within the Champlain Lynn hospitals. There is a HSAW or Hospital Services Accountability Agreement between EORLA, between the Champlain Lynn and the individual hospitals regarding the formation of EORLA as a voluntary integration. EORLA is member owned. It was actually incorporated on April 15th, 2003 and is not for profit. There's board representatives. I note that Queensway is one of them. I'm not going to go through the list, but you can see the individual members. And if not already on it, the presentation will be on our website for people to look at. But it represents basically the members that are the participants in EORLA. So it's a member-owned organization. Members are both owners and customers. What's the rationale for EORLA? The rationale for EORLA is that the intent is to have a standard, high-quality service across the Champlain Lynn. That is not to say that quality doesn't exist now, but what does occur is there is a variety of ways of doing a test, and there are different ways of delivering it, and the intent is to standardize that. I'll be frank, one of the intents is also to gain efficiencies in delivery of the service. Part of that, though, is to be able to reinvest the savings for gaining efficiencies to look at new ways of providing the service and new tests. So the consistency of testing across the Lynn, quite frankly, now is an issue. If I went to one hospital and got a PSA done and I wanted another one in 2 years, unless I went to the same hospital and had the same thing done again, the results are not comparable. So in following people with chronic disease like diabetes or thyroid disease or cancer, really is incumbent upon laboratories to be able to provide a more seamless service than they have historically been. And that's not something that just occurs in the Champlain Lynn, that's across much of the country and across the world. And it was pointed out by one physician I used to work with, why do I have to sort that out? And why is it? And they can't, and nor should they be expected to. The other expectation is that people, when they move from, either they come from Carleton Place into Queensway, or from Deep River to Pembroke, or from Queensway to somewhere else, physicians and other healthcare providers shouldn't have to redo the testing to get the results. Maybe that's really what happens now. Want to know what happens? Just do the test again. Oh, and by the way, it's even compounded when the test comes out and it's done in a little different way and it's not equivalent. So what's EORLA's plan? The plan is to have a standard and consistent approach across the Lynn. To accomplish that, laboratory staff, so MLT's unionized staff, will be transferred to EORLA effective April 1, 2012. As part of that, and in anticipation of that, the plan is to transition management staff this month And the rationale for that is that that will allow things to be established and in place when staff move in April. So not everybody moves at the same time. The actual employment will change actually for people in April. And EORLA will be responsible for the laboratory services, and we are developing some of which are already been developed, and there will be additional ones developed that EORLA will provide a service against a set of predetermined performance metrics, and those are consistent from site to site. Since EORLA will be the employer, the question is how does EORLA get the money? EORLA will be billing its member hospitals for the work that's performed. Queensway, along with many of the other organizations, had their chief financial officers involved with Mr. Letourneau and EORLA to develop the funding model, which is now complete in principle. EORLA has also developed a business plan and will be looking for areas of opportunity to gain effectiveness. Oops, sorry. What will EORLA do? In terms of the staff, the expertise, experience, and seniority will be recognized, and it is not EORLA's intent to do away with education or training. It's actually EORLA's intent to enhance, enhance the participation in training and education. In part, as we came up with last meeting, that's really one of the major ways you have the laboratory staff that we all need on a go-forward basis. Will maintain and enhance quality, and ultimately actually is a means of addressing two things that drive issues with all laboratories. Number one is the challenge of finding people with appropriate skills, hence the term scarce skills. For many things, it's at least a national and many frequently an international market, and the demographic changes of the workforce. And one of which, another opportunity will be that EORLA will provide opportunities for staff in terms of where they want to work. I know that many people want and everybody will have a home hospital laboratory. Many people don't want to move, but some people actually do want to have the ability to move across the region, and the EORLA enhances that. Coming back to the efficiencies, new tests and methodologies will be developed and deployed, and our intent, and this is part of it, is to communicate with the member hospitals and clinical services to ultimately what happens is that laboratory services remain matched to meeting clinical needs. What EORLA is not. EORLA is not about downsizing and layoffs, and I'd just like to say that again. EORLA is not about downsizing and layoffs. This is not about restructuring to do things with less people, and the challenge we have is finding the number of people we need in the workforce, not to reduce it. EORLA is in negotiation with OPSU regarding its first collective agreement. That's ongoing. As that reaches a conclusion sometime in the future, we'll communicate with you about that. And I can't say what they're negotiating about because that's part of the reason that they have negotiations. A couple other things I point out is that there's an EORLA website. We'd encourage you to visit there. There is the opportunity to ask questions. Also, newsletters that EORLA has produced are on the site, and you can access them. EORLA is working on a lab information system. Currently, there's a project that involves the Ottawa Hospital, CHEO, and Cornwall. It's Cerner Millennium. It's not necessarily the only LIS that EORLA will have, and I know Meditech is here, and I'm familiar with Meditech, and it's a great system. The challenge for EORLA is right now across the LIN, depending on how you want to count subsystems on different versions of the same software, which are functioning, there's 20 LISs. That's an awful lot of data fragmented between disparate systems. So the intent of developing the Millennium is that there is, for several of the hospitals, an opportunity to move to a common platform, and we'll continue to do that. I'm not fixated on having one LIS. I think there should be a concerted effort from reducing it from 20. Oh, and EORLA will not be creating its own HR department and finance department. We will be leveraging the members' back office functionality or support functionality so that we don't incur unnecessary costs. There's a draft organizational chart. We frequently have the question, but we can come back to this in the question and answers. The right-hand chart, right-hand side of the chart has a regional approach, and the intent is actually not unlike that of the Valley Lab program to address hospitals in clusters. On the left side, though, is a subject matter approach, and that will be regional. So this comes back to standardization. So there will be a way of doing a test that allows the test to be comparable from laboratory to laboratory. And there's usually a lot of questions about this. We'll come back to this. So, oh, well, there you go. Anyways, that wraps it up. I tried to get through it quickly, and I really look forward to some questions and answers. Sometimes I find if it's a smaller group, there's some hesitance. Please, there's no right or wrong answers. If you have anything to ask, please let us know.